So I'll invite Dr. Anuj for taking over for the next session and invite the chairpersons.
Good morning, everyone. So in continuation with the previous session on the small renal masses, I would request the chairpersons, Dr. Mahesh Desai, Dr. Premnath Dogra, Dr. Dilip Kamarkar, and Dr. Wahidu Zaman to be on the stage. And the voting would be conducted by Dr. Rajesh Nair and Dr. Rajesh Kumar Reddy. Okay, so I would like to now invite our first speaker, Dr. Simon Hughes, who will be conducting the speak on the role of SABR in small renal masses. Dr. Simon.
Thank you. So a lot of this is going to be familiar because you had an excellent first session this morning. So I'm going to go through this quite quickly so we can catch up a bit of time. So just like surgeons have their robots, radoncs also have our toys that we like to play with. And I think one of the things that's enabled SABR and SBRT, as you heard earlier, stereotactic ablative radiotherapy, as we call it in the UK, or stereotactic body radiotherapy, to occur has been technological advances. So we're now able, with the computing systems, to plan much more complex radiotherapies, very tight dose fall loss adjacent to the tumour. We've got onboard imaging on most of the treatment machines now, or we can track the tumour motion as well. So what it enables us to do is highly focused radiotherapy. So effectively, we're delivering biological doses that are 3 times higher at least than conventional doses. It's why it's far more effective. My personal preference for treating renal tumours is we use a CyberKnife to track it, or we use an MR-Linac and we gate the treatment. But basically you can deliver these treatments on any of these platforms, and all of the platforms have their idiosyncrasies that mean that you can do certain tumour types better on one platform than another, but they can actually all do this. So this is the evidence really for SABR. And firstly, the studies are all low patient numbers. They're all non-randomized, they're largely retrospective, and that means that there's less capture of any toxicity associated with the treatment, and maybe also we haven't recorded the comorbidities, and there's also short follow-up. But basically all the cases that we've used to date for these studies are medically inoperable, or they've declined surgery, or they're high-risk surgical candidates. So these are all non-surgical candidates. What we haven't done is look at this in patients that could have an operation. So that needs to be important. You've got to bear that in mind. That's the evidence base for these treatments. So there's basically 3 studies that I wanted to mention. They've all been mentioned earlier. So the first one is the IROC. So this is the 9-centre retrospective study. Only 223 patients out of 9 centres, and they delivered 1 to 10 fractions, 31 medium follow-up. Now the most important thing here, you're looking at 4 years, local control, 97.8%. I think cancer-specific survival and progression-free survival, if you've got that local control, is irrelevant, because that's the nature of the disease as it's spread already. The local control is the important thing we're looking for here, and that's 97.8%. Toxicity-wise, if you're looking at that, grade 3 and above, only 1.3%. So it's an effective and safe treatment. And if you look at the change in GFR, the mean reduction is 5.5 mils, but a quarter of patients had an improvement in their GFR, because if you're shrinking an obstructing lesion, you can actually get an improvement in the outflow. Second one is a meta-analysis. So that's 26 studies. 11 of those are prospective. So about half of these are prospective data collection. 372 patients. So again, that shows you 26 studies to get 372 patients. Shows you how small the studies are. Again, these are inoperable, localized mainly. Some of these are in the metastatic setting. The diameter is 4.6 centimeters, median age 70. And these are the 1, 3 or 5 fractions, decent follow-up. And again, Local control, 97%. And the failures were tended to be patients that had lower doses, and the doses were lower due to adjacent organs, for example, the bowel, which necessitated a dose drop. Toxicity again, look, 1.5% grade 3 and above. Even grade 2, only 8.8%, nausea, fatigue, skin, and a small reduction again in GFR. About 3% needed dialysis, but they had existing severe renal dysfunction. I know I've treated people with GFRs in the 20s because we had no alternative. They were bleeding, we had to do something. And then this is the last one, Fast Track 2. So this is a non-randomized phase 2 study. Again, unsuitable for surgery, medically inoperable, high risk, decline surgery, biopsy confirmed, single lesions, and for the group we're looking at, so the 4 centimeters and below, single 26 grade fraction. So they've got 70 patients, median age 77, so quite an elderly population. Charleston score 7, so that means they've got pretty significant medical comorbidities, which explains why they're medically inoperable. And they used a renal complexity score, which I've just popped here. So this is a way of just looking at how complex was the tumour. So they're looking at the radius of the tumour, whether it's endophytic or exophytic, how close to the collecting system, location, relative to this polar line, which we've got on here as well, and whether it's a hilar tumour. So in this study, 7 to 9, we've got a complexity score of 8 here, so it's a moderate complexity. So they've got 10% grade 3, no higher grade toxicities though, and 16% of patients had no toxicity at all. Local control, 42 months follow-up, 100%. The other things I think are less relevant, that's down to the nature of the disease, but the median fall in GFR at 2 years, 14 mils per minute. So if you can try and compare SABRE and focal therapy, now you can't really do this because they're all different studies, different trials, but these are the 2 meta-analyses, and I just think what it shows is that there's a lot more data still on the focal therapies that are non-ionizing. The follow-up though in our meta-analysis was longer, and again, if you're looking, I think we've got the same ballpark. It shows they're both effective treatments. The SABRE studies, they tended to have larger tumours than the focal therapy studies, but both studies have found that there are worse outcomes with larger tumours, and with SABRE if we give multiple fractions, which often goes hand in hand with having a larger tumour. So summary, to date we've only been using SABRE when surgery is contraindicated, so medically inoperable, patient declined surgery or high surgical risk, or if there's a high risk of needing dialysis afterwards. It's safe, feasible and effective. We've got good local control, minimal effect on renal function. Although we're talking about 4 centimetres and below here, we'll go up to 10 centimetres now, accepting that we'll get a worse outcome for a 10 centimetre tumour compared to a 2 centimetre tumour. And again, we only look for patients with a decent performance status and a life expectancy of at least 6 months. Otherwise, the renal mass is insignificant. Thank you. Oh. That's my other profession, professional rickshaw racer.
Thank you, Dr. Simon, for explaining the role of SABRE in its application in the small renal masses.
So I think we're going to do some voting now. So if everyone has their little keypads, we're going to do a few statements now. So SABRE for small renal masses should only be offered in high volume centers, so you need a minimal level of expertise or experience. Patients with surgically resectable small renal masses can be offered SABRE as an alternative management option. Patients with surgically resectable small renal masses but decline surgery can be offered SABR or SBRT as an alternative management option. Patients with a surgically resectable small renal mass but are high risk due to medical comorbidities can be offered SBRT or SABR as an alternative management option. So here it's medical comorbidities which is the difference. Patients with surgically resectable small renal mass but who are inoperable with medical comorbidities can be offered SABR or SBRT as an alternative management option. So here are inoperable medical comorbidities. Patients with a surgically resectable small renal mass but who are at high risk of needing dialysis post-resection can be offered SABR or SBRT as an alternative management option. Any radiotherapy platform can be used to deliver renal SABR or SBRT.
At least people are honest.
And what is the optimum non-surgical therapeutic option for small renal masses in terms of outcomes? A, cryotherapy, B, radiofrequency ablation, C, SABR or SBRT, D is other, and F is not my specialist field. What is the optimum non-surgical therapeutic approach for small renal mass in terms of cost? And this is for your own local populations in terms of cost. Cryotherapy, radiofrequency ablation, SABR or SBRT, other, or not my specialist field. And lastly, what is the optimum non-surgical therapeutic option for a small renal mass in terms of toxicity? Cryotherapy, radiofrequency ablation, SABR or SBRT, other or not my specialist field.
So after completing the voting session and a lot of honest answers of F, not my specialist field, to be seen in this session. So I now invite Dr. Sanjoy Sureka, who is Assistant Professor in the Department of Urology and Renal Transplant, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and he will be delivering his talk on the role of radical nephrectomy for small renal masses. So.
Anyway. Yeah, welcome you all at the City of Joy. I had a very melodramatic fond memory of my childhood in this city. So I'd like to thank Dr. Ghosh and Dr. Ravi for inviting me here. So I'm going to talk about role of radical nephrectomy in small renal mass. So I have a very important disclosure that I am pretty biased for partial nephrectomy. So with this disclosure, I would like to start my presentation. So I'll talk about T1A renal mass, and my overview would be like I'll talk what is the standard of treatment and what is the kind guidelines in a small renal mass, and when radical nephrectomy may be a better option with 2 or 3 case scenario, and I will look into the evidences how and why partial nephrectomy is little ahead than radical nephrectomy in small renal masses, and I will finally give my comments and take home. So if you see the EUA guidelines 23, the first and most important statement is offered partial nephrectomy in patients with T1 tumors with a strong rating. But you see the subsequent statement, you will find the oncological outcome in terms of overall survival following partial nephrectomy is equal to of radical nephrectomy in patient with clinical or pathological T1 tumor. So of course I feel there is the 2 tables is just 1 by 1, though there is some contrary. And if you see the NCCN guidelines 2023, you will find that again the partial nephrectomy is the preferred treatment. However, there are selected cases when radical nephrectomy may be an option. So I will see what may be those selected scenario or radical nephrectomy may be an option over partial nephrectomy. Say for one case scenario, a 60 years old gentleman who underwent CABG and 4 centimeter infiltrating mass and opposite kidney is normal. How many of you will go for partial nephrectomy? Can you raise your hand? So very few. I think majority will go with radical nephrectomy. The second case scenario is again comorbid patient with a history of MVR with a rheumatic heart disease with ejection fraction of 40 on anticoagulants, recurrent hematuria with a complex mass on the left side. This is the image. So how many of you will go for a partial nephrectomy? Again, I think many of us will favor for radical nephrectomy. So this is another scenario, a small renal mass in ESRD. I think definitely all of us will go for a radical nephrectomy. This is a small renal mass in elderly gentleman who is more than 75 years. The opposite kidney is normal, very complex endophytic mass. So how many of you will go for partial nephrectomy? But still majority is willing for radical nephrectomy. So there may be very special case scenario when before going to the definitive treatment, you know the biopsy, like a very aggressive treatment, aggressive tumor like circumdead RCC, maybe collecting data of Bellini tumor. So in this kind of scenario, probably partial nephrectomy is not a good option. So now I will look into the evidences, how the partial nephrectomy or radical nephrectomy fares in terms of cancer-specific survival and overall survival, preoperative outcome and functional outcome. So if we look into the literature, most of the studies comparing the oncological outcome for 2 surgical approach are mostly retrospective and include a cohort of heterogeneous tumors and the varied approach. There are only one RCT which was prospective good evidence. However, it was a very prematurely underpowered study and which found that probably the partial nephrectomy is non-inferior in terms of cancer specific as well as overall survival as compared to radical nephrectomy. And this is the best evidence. We know this was a very famous article in which was published in 2011. And if you see, very surprisingly, that this study found in when they analyzed intention to treat population, they found the radical nephrectomy has better survival outcome as compared to partial nephrectomy. However, when they done subgroup analysis and they only took the patient who had RCC after pathological evaluation, then they found the difference in terms of OS was not that pronounced and more or less same. So cumulative time to progression, again it was 10 years, progression rate was same in between two groups, recurrence rate again the same. So what they conclude that both radical and nephron sparing surgery provides excellent outcome in terms of oncology and overall survival. However, the number of progressions and death from the renal cancer in their study was too little to make a correct statement or explain why there was a difference. Then I went into and I read a review article by Cochrane and in which was published in 2017. And I am not going in depth of that review article. I will just highlight what they have written, that partial nephrectomy preserved kidney function better after surgery, of course, no doubt. Probably that lowers the risk of development of cardiovascular diseases. Definitely this is also true. And on that basis, there is little improvement of survival for partial nephrectomy as compared to radical nephrectomy. The weak evidences are weak because most of those studies are retrospective and underpowered. However, in some other retrospective studies, they found this is held only true for patients who are young or patient without significant comorbidity. I have already discussed about the prospective randomized study, which I have already shared, that which was prematurely closed and heavily underpowered, and they found that partial nephrectomy seems to be less effective than radical nephrectomy in terms of OS. So taken together, the OS advantage suggested for partial nephrectomy versus radical nephrectomy remain an unresolved issue even today. So if I look into the perioperative outcome, the most of the literature is at the same agreement, and they found probably partial nephrectomy had slightly higher rate of complication but can be safely done in a small renal masses, and level of evidence was intermediate. In terms of other functional outcome, in the review article they found the partial nephrectomy definitely preserved the kidney function, that is intermediate level of evidence. However, there is a very important point to understand, that after radical nephrectomy, though they have lower GFR, but they are surgical CKD, and the progression of surgical CKD is far less as compared to medical CKD, and adverse overall survival in patient does not seem to be result from surgical CKD rather than from other medical comorbidities causing pre-surgical chronic renal diseases. So this is very important to understand. And there are only two articles who have focused on quality of life following partial or radical nephrectomy, and they found quality of life is ranked a little higher following partial nephrectomy as compared to radical nephrectomy, but with a low level of evidence. However, general patient's health status deteriorated following both approaches. So when I analyzed the whole evidences and my critical analysis, I felt that when you are considering any patient for radical nephrectomy in a small renal masses, two important factors to be considered. One is tumor factors. In a patient with a very complex infiltrative tumor, especially when the patient factors are also on the same agreement, that their patients are elderly or having a poor performance score or poor surgical candidate for partial nephrectomy, or patient is not willing for partial nephrectomy, they are probably candidate for radical nephrectomy. In 2017, the ASCO has also recommended their own formulated guidelines for management of small renal masses. These are lines just I have quoted from them, ASCO, and this said radical nephrectomy definitely has limited role, we agree with all. And however, in setting of a normal contralateral kidney, in a complex tumor, the radical nephrectomy can be considered, and it should be done in minimally invasive approach. So their recommendation was radical nephrectomy for small renal masses should be reserved only for patient who poses a tumor of significant complexity that are not amenable to partial nephrectomy by an expert surgeon. When partial nephrectomy may result in unacceptable morbidity even when performed at the centers with expertise. And whenever patient, if you feel that patient is not suitable for partial nephrectomy in a small renal masses and your center is not a high volume center, they suggested that patient should be referred to a high volume center with expertise surgeon. So to take home, I also believe that partial nephrectomy is the treatment of choice in small renal masses, but of course radical nephrectomy has its own place, especially when partial nephrectomy is not feasible even in experienced hand. It unacceptable perioperative risk or morbidity, especially in patients who are elderly with a suitable clinical setting. There may be a very small subset of patient like when there is a aggressive tumor biology, we know beforehand going for surgery. Radical nephrectomy may be a suitable option. So I am also biased, and I also believe that partial nephrectomy is the most preferred option. And contrary to popular belief, I really like to have a good time at the dais, so not take myself too seriously. Thank you. I also like to acknowledge Dr. Gidhar for giving me some suitable and important image. Thank you. So I think I have finished in time. If any question that can be asked right now, if baad mein? Okay, thank you.
So the questions of the whole session will be taken together. So now we'll go for the voting for the statements.
So we'll go for the next set of questions. The first question, radical nephrectomy for small renal masses should only be offered in high volume centers. Yeah, next question. Patients with T1A small renal mass can be offered radical nephrectomy as a management option. Third question, patients with T1A complex that is potential to be T3 small renal mass can be offered radical nephrectomy as a management option. Statement 4. Patients with T3A small renal mass can be offered radical nephrectomy as a management option. Statement 5. Patients with central small renal mass close to the hilum can be offered radical nephrectomy as a management option.
Last statement, patients with central small renal mass close to the collecting system can be offered radical nephrectomy as a management option. Thank you.
So now I would like to invite Dr. Sanjay Adla. He is consultant uro-oncology at Apollo Cancer Institute's Jubilee Hills, Hyderabad, who will be speaking about the role of nephron sparing surgery in small renal masses. So,
thank you very much for the opportunity. And okay, it comes up. I just wanted to make sure that I'm looking better there than here, so that's why I included photo in my first slide. And this is a slide. I had three purposes, so that all of you can wake up. Second, I'll start off with the climax. And the third and most important one was, these are all aging icons, indicating that majority of the evidence that I'm going to present is prior to 2015, 2017. Even the meta-analysis was from 2017. So the case is already made, and I'll start off with my conclusion. So these are my conclusion. In that, do a partial whenever feasible. That's the standard statement, and I will see if I can find evidence to back that statement. These are the 4 questions that I thought you will be asked. Why do a partial? Why in India? When to do it and how to do it? So since this case series of 35 management of renal masses was published in 1969, radical nephrectomy was the standard. Until this gentleman, and we were doing this, and I remember doing this in 98. We were doing radical nephrectomies for everything. And this used to be a typical specimen that we had. Until this gentleman came along and said, probably we don't need to be doing it. Okay? Why? If I'm proposing, it is no more a new treatment. I'm not proposing something that is novel treatment, but I'm just trying to find evidence for what we do as a standard. If I'm going to say partial nephrectomy is equivalent or better, oncological is similar, lower risk of renal failure, thereby leading to better overall survival. Those are the 3 points. As you can see, this data is from early part of this millennium, early part of this century, not millennium. So this was saying that at 10 years, whether you do a partial nephrectomy or a radical nephrectomy, if you see here, its follow-up is 200 months. Cancer-specific survival is similar, if not slightly better with partial. This one at 10 years, cancer-specific survival, whether you do a radical nephrectomy or a partial nephrectomy, it is same. So oncologically, I'm doing a good enough job if I do a partial nephrectomy. Then I might as well do a straightforward radical nephrectomy. If their oncological is similar, why should I do a more complex partial nephrectomy? The reason, this is often quoted, this is the 1B evidence whenever we want to justify a radical nephrectomy. They were planning to recruit 1,300 patients. They recruited around 400 patients. And it was accrued over a very long time period. And the size of the tumor mass in this was less than 5 centimeters, which was T1A at that time, not 4 centimeters that we use now. So what did this show? Saying that they are equivalent. So the problem is of the chronic kidney disease. I said the oncologically they are the same, but by doing partial nephrectomy, do I decrease the chance of chronic kidney disease? If so, what does that mean? So this is freedom from eGFR being less than 60 ml or less than 45 ml. And as you can see, when you do a partial, the chance of somebody ending up with chronic kidney disease stage 1 or 3 is lower when you do a partial compared to radical nephrectomy. And this is a better way of studying, a population-based study, quite a large number and a much longer follow-up, 77 months, okay, 5,670 patients. And these were the questions they were asking. So what you see is, just see the hazard ratio. The chance of somebody developing CKD when you do a partial nephrectomy is 0.18 compared to 1 when you do a radical nephrectomy. That is astronomical numbers. And when you see even the chance of having renal replacement therapy, it almost decreases by 75% when you do a partial compared to do a radical nephrectomy. Why is that important? This is the relationship between the GFR and the risk of death and cardiac risk. So it isn't that somebody who is on renal replacement therapy, somebody who has got a creatinine clearance of 45 is at a higher risk compared to somebody who has got a creatinine clearance of 60. So it keeps on increasing. So the more we preserve, the better it is. And that's what it leads to. You have a better overall survival when you do a partial compared to doing a radical nephrectomy. So cancer-specific survival is same. Overall survival is superior with partial compared to radical nephrectomy. Then the important question, why in India? And these are the last one is India. As you can see, the population more than 20 years in India is close to 1 billion. We have got 900 million adults in India. When you look at the incidence of overall CKD, when you look at population-based study, it is 12%. When you look at institutional studies, it is almost 16%. That is eGFR less than 60. In our adult population, it is 16%. And when you look at CKD3, it's 2% of overall adult population already have a GFR less than 30. That is why there was one country wherein we should be preserving kidney, it is India. When do we do it? We used to do it in T1A. Now there is good enough evidence to do it both in T1B as well as T2. So this is a meta-analysis of comparative studies. There are no randomized controlled trials. There is only one randomized controlled trial, which was the EORTC. And what this showed is, in T1B, this is a forest plot. If you see favors partial, favors radical. Complications, it will always be less with a radical compared to a partial. But when you look at the postoperative eGFRs, favors partial nephrectomy. Onset of CKD favors partial nephrectomy. When you look at tumor recurrence, favors partial nephrectomy. This will be a bit biased one because these are all pre-selected patients. Cancer-specific mortality, better with partial. Overall survival, better with partial. How do we do it? Whether we do it as open, laparoscopic, or robotic. I'm just using two comparators, ischemia time and complications. So I didn't take my own series, I took somebody who is very experienced, 1800 laparoscopic partial nephrectomies comparing to his own open partial nephrectomies. And when you look at ischemia time, in this large series, laparoscopy it was 30 minutes compared to 20 minutes in open. The less the warm ischemia time, the better it is. And when you look at this Indigil series, intraoperative complications are double. Postoperative complications are double. Postoperative hemorrhage is almost 3.5 times. Return back to theater is almost 3 times. So whenever you compare open to laparoscopy, open is safer. This is my own, when I say learning curve of my first 82 open partial nephrectomies and robotic partial nephrectomies. I'm not the best surgeon in the world, but still they are comparable. Warm ischemia time compared to cold ischemia time. Statistically significant, but not numerically. And all the numbers are matching up. It is quicker recovery with the robotic partial nephrectomy. So how do we do it? Whether we do it robotic or laparoscopic or open, partial nephrectomy is the standard. Robotic approach seems to be superior, but the surgeon is the key, not the approach. Thank you.
Okay, we're going to do some voting now. So we'll start with number 1. Nephron sparing surgery should always be offered where technically possible. Nephron sparing surgery for small renal masses should only be offered in high volume centers. Patients with T1A, clinically T1A, small renal masses can be offered nephron sparing surgery as a management option. Patients with clinically T1A complex, i.e. they have the potential to be T3 on final pathology, small renal masses can be offered nephron sparing surgery as a management option. Patients with T3A small renal masses can be offered nephron sparing surgery as a management option. Patients undergoing nephron sparing surgery for small renal masses should have an intraoperative frozen section. Patients with ipsilateral recurrence of a small renal mass following previous nephron sparing surgery can be offered a second partial nephrectomy. Patients with focal positive surgical margins following nephron sparing surgery for a malignant small renal mass should be offered a completion nephrectomy. Patients with extensive positive surgical margins following nephron sparing surgery should be offered a completion nephrectomy. So these are extensive positive margins now. And finally, if a patient is undergoing nephron-sparing surgery and intraoperatively a small thrombus is found in a segmental vein, the surgery should be converted to a radical nephrectomy there and then. Okay, great.
When you put it as a paper, I think there should be a small correction. Small renal mass CT3A would not be by definition by CT3. So either you delete the small renal mass and give CT3.
So heading towards the final presentation before the lunch, I would like to invite Dr. Tushar Aditya Narayan, who is consultant uro-oncology at Max Super Speciality Hospital, Saket, and he will be speaking about the future research themes in small renal masses. So.
There's a small correction, it's not me. My colleague Kumar Madhavan, an assistant professor from AIIMS Bhopal, was to present this talk, but he's unfortunately not well, so he sent across a presentation with his voiceover. So I'll play this presentation, and if you have any questions in the end, I'll be happy to take the questions on his behalf. Can we play the presentation, please? For it's Kumar Madhavan presenting this presentation.
Faculty and dear colleagues, I'm Dr. Kumar Madhavan, an associate professor at AIIMS. I'll be discussing future research themes in small renal masses, and I've divided my topic in
Voices. Can you check the sound, please?
to epidemiology and health economics, diagnosis and surveillance, management and survivorship. Now, I went through the clinical trial registries of India, the United States and the WHO. Unsurprisingly, I could not find even a single ongoing trial on epidemiology. There were a lot of ongoing trials on management and diagnosis. In fact, more than 200 trials turned up, and there were some on survivorship as well, but nothing on epidemiology and health economics. So that's where I've decided to spend some time on. Now, we will not be discussing familial RCCs because that's a different topic altogether, and I'm very thankful to USI for giving me an opportunity to write a chapter on that, which will be a part of the upcoming urological clinics of India. So the presentation of small renal masses is very varied in our setup. It's really not that common. In fact, since I have joined AIIMS Bhopal from August 2021, we have done 58 renal cancer related surgeries, and we have seen only 71 AMASs. This is somewhere around 10 to 12%, which is similar to the data from a paper by Mandani sir, who I expect would be in the audience today. So even this data from SGPJ shows that just around 10% of all renal masses are T1A and below. The incidence of RCC in India is around 1 per 100,000. This is less than 5 times what is seen in the Western literature. Now, this was another paper from ICMR, which was a detailed report on various malignancies in India, and this did not even mention the word kidney even once. So does that mean that it's not really a significant health problem? Well, that wouldn't be true, because it's a very lethal cancer with around 50% mortality rate. That said, the lifetime cumulative risk is just around 1 in 620, which is lesser than that of CNS tumors, much lesser than urinary bladder tumors, and definitely much lesser than the common tumors that exist in our country. Does this mean, well, this could be because of 2 reasons. One is the obvious fact that definitely the incidence of RCCs is lesser than when compared to other cancers, and also it could be because we're not doing enough ultrasounds. So does that mean that can we consider starting a screening trial in India? This is sure to stir up the hornet's nest. In fact, I would agree that the most likely answer is no for the general population. But it's still worth discussing, and let me discuss some pros and cons. So it has a low incidence of 1 per 100,000 in India, but some screening trials have shown that incidence may actually be much higher, in somewhere in the range of 23 to 300 to even 300 per 100,000. Of course, this needs to be confirmed by further trials. Additionally, when we do an ultrasound for renal masses, we will be able to diagnose stones. Stones are very common in India. In fact, in our center, we do many more simple nephrectomies than we do radical nephrectomies. So we may be able to reduce that number as well. That also means that we'll get a lot of false positives in the forms of cysts and adenomas. This brings in question survivorship, because not everyone will be happy to hear that he has a simple renal cyst. There will be some anxiety, and these patients are very likely to get a second opinion. So it's going to add to the cost to the patient, and so we have to look into this as well. As we know, not all SRMs are lethal. Now we can reduce these cons by adding some specific inclusion criteria, such as those related to etiological factors, say gender-related, obesity, hypertension, or smoking. But despite all this, I did some calculations, and the number of patients that we would require for such a trial would be somewhere between 50,000 to 200,000. And if we don't ask the patients to pay for their ultrasounds, the cost of such a trial would be upwards of GBP 2 million or 20 crore rupees. And this is despite the fact that an ultrasound is relatively inexpensive in India, costs just a tenner around 1000 INR. And it's a good investigation. It is more than 95% specific and 80% sensitive. So it's probably worth discussing this in a brainstorming session that we may be able to plan a screening trial in India. Now, when it comes to blood and urinary biomarkers, this is where kidney is different from, say, prostate and bladder. I mean, prostate has PSA, bladder has blood in the urine. But kidney does not have a very good biomarker available. There have been some trials. Some biomarkers have been shown to show some correlation with the growth rate of small renal masses, but the sensitivity and specificity is very poor. It's even worse than the urinary biomarkers for bladder cancer. So it's an area where further research can be done, and there is an ongoing trial in Denmark, which is called the NISA trial, which is looking into the total number of total nucleic acid in urine and blood. So this is definitely an area we can look into. Coming to diagnosis and surveillance, contrast-enhanced ultrasound has come up in a big way. It is routinely being used for follow-up of small renal masses in many parts of the world, including my own center where I worked in the UK. It has the potential to replace cross-sectional imaging as a follow-up tool for patients on active surveillance or even those following ablative therapies. And there is an ongoing American trial where what they're doing is they're following the schedule of cross-sectional imaging following ablative therapy, that is 3 months, 6 months, and then annually. And following that cross-sectional imaging, they're doing a blinded ultrasound 7 days following that study. So this way, they're trying to correlate whether CUS will be able to replace cross-sectional imaging. The other questions that we really need to answer is that whether cross-sectional imaging can whether CUS can differentiate between benign and malignant renal masses, because that will be an important point, and whether it can differentiate between slow and fast-growing SRMs. Now, there is some evidence to suggest that it can differentiate between clear cell and the other types of renal malignancies, but can this really translate into differentiating between benign and malignant renal masses? A similar question is being asked about multiparametric MRIs, and a French study is ongoing which should be able to answer some of these questions. That brings us to the Achilles heel of management of SRMs, because we have not been able to randomize patients. There have been attempts in the past, such as the CONSERVE trial at Newcastle, another trial which was in the UK, the SURAB trial. This was a trial done at 8 centers, and they could randomize just 6 patients. Another American trial which tried to randomize patients between radiation and RFA, that could only randomize 1 patient. So this has been difficult, and randomization has really been a big problem for us, and predictably so, because it's very difficult to randomize a patient into all three arms of nephron sparing surgery, ablative therapy, and active surveillance. But we may have a solution to this, and I will briefly discuss it at the end of my presentation. Now, most of the trials that are ongoing when it comes to ablative techniques are basically retrospective and prospective registries. So we may have some long-term outcomes available in the distant future, but we don't have any ongoing RCTs at the moment. When it comes to nephron sparing surgeries, there are some interesting trials going on, especially an American trial where what they're doing is they're asking patients with small renal masses to actually donate their entire kidney. So they're doing radical nephrectomies for these patients, and they're transplanting the normal part of the kidney after ensuring clear surgical margins into patients who are otherwise not great candidates for transplant, such as HIV positive patients, patients with active malignancies, or patients who have life expectancy of less than 5 years. Now, this does raise a lot of red flags. Not something I'm recommending, but yes, that's something that's going on. Radiation has been tried for SRMs with good short-term results, but again, long-term results and randomization is something we've not been able to achieve, and that is something we can look into in very selected patients. Photodynamic therapy was tried at the University of Oxford, but again, that trial was terminated because the post-MDT MRIs were inconclusive. So that brings us to the final questions. So where is the evidence lacking, and what can we do next? So the first question is, how do we detect more SRMs in our setup in a cost-effective manner? How do we select biomarkers that help us decide management? Can we use contrast-enhanced ultrasound to replace CT and MRI, especially for follow-up imaging? And can we use them as tools to differentiate between benign and malignant tumors, and between slow-growing and fast-growing SRMs? The same question will be applicable when it comes to biomarkers as well. Also, we do need some more patient-related outcome measures on survivorship, especially if we do a screening trial that we discussed earlier, because that will give us a lot of false positives. Now, as we discussed, that there is not enough evidence at the moment to allow ethical randomization. So it's very hard to imagine a single patient who would be eligible for all the three arms of ablative therapy, active surveillance, and nephron sparing surgery. So now the problem here gets magnified by the fact that RCC has a low incidence. So in fact, if we could somehow start a screening trial that could feed patients to a further trial, which could randomize those patients, because then we'll have a pool of patients with small renal masses, and then we probably randomize those patients depending upon their fitness level into AT versus nephron sparing surgery, or into active surveillance versus ablative treatment. So I believe this summarizes the future research themes in small renal masses. Over to the audience for further discussion, and Dr. Tushar will take questions on my behalf. Thank you very much. Respected senior faculty and dear colleagues, I'm Dr. Kumar Madhavan, an associate professor at AIIMS Bhopal. My apologies for not being...
Yeah, thank you. So that was Kumar Madhavan's talk on the future prospects of research for small renal masses. I'm happy to take any questions if anyone has any questions regarding research in the field of small renal masses. I think we are good. No one has a question. We can go on with the voting. Thank you.
Thank you, sir. We'll proceed with the voting. Genomic profiling of small renal masses undergoing active surveillance. Second statement, does treatment of small renal masses improve outcomes? last statement, functional imaging to determine the biology of small renal masses. Yeah, we're done with the voting. Thank you.
Thank you, sir. So after all these presentations, now we can have questions from the house as well as comments from our chairpersons.
My question to Sanjay, my friend.
Two Sanjays
All
are
of
there.
us believe.
So there are two Sanjays. You have to specify.
Oh, sorry, Adala. Both of you are friends, by the way. Okay, Sanjay, the question is that it looks like a no-brainer in this crowd to think that a partial, which is possible, everybody will do. T1A, forget it, T1B, all the champions will do, T1B also, maybe T2, not everybody will do. Why is it that we haven't been able to do a randomized trial? That too hasn't shown anything. What do you think has gone wrong?
Okay, so it's not criticism of the random. To do any surgical randomized control trial is exceptionally difficult. There are a lot more learned people in front of me, so I don't want to talk about the difficulties. But they aim to provide evidence based on 1,300 patients. They recruited almost 470 patients. So it was severely underpowered. Then the second element of it is, there is always, whenever I could have made a very good case for doing radical nephrectomy for SRM, because I think we don't ever go into those, because surgically, like the only one that we got a consensus reaching 75% is, whenever as surgeons we can operate, we'll be able to agree saying that we'll do a partial. So the way I look at it is, by doing a partial nephrectomy, am I doing them any harm? And the straightforward answer to that is no. Probably I'm doing them some good as well. So that's my rationale for doing a partial whenever it is feasible. However, the complication rate in the best of the hands is almost 3 times more whenever we do a partial nephrectomy compared to doing a radical nephrectomy. It might be 1.5% going up to 4%, but that is still a 3-time rise. Hopefully I've answered your question.
Sir, one more extension of this discussion. Can we offer a partial nephrectomy if it is feasible in a case of metastatic RCC? If it is feasible, it's a small tumor, not complex. Other than that, he is having a lot of metastasis, and if we are doing a cytoreduction or whatever, is it feasible to, is it okay to offer partial nephrectomy?
Okay. No, on 2 fronts. First of all, there isn't anything called a cytoreductive nephrectomy as of now in 2023. So when I can't even make a case for doing a radical nephrectomy to make a case for partial nephrectomy, definitely no. There is a lot more tumor elsewhere. Give them systemic treatment.
No, not on that. The thing is, it has been decided to do nephrectomy. I'm not debating about the indication for nephrectomy or not. I am saying that somebody is doing a radical nephrectomy in metastatic RCC. If it is feasible, is it okay to do partial nephrectomy in that case?
I would still, because there are so many ifs in it, my answer would be no.
Okay. Can I take that question, sir? Can I answer that? So probably if it's just for palliation of symptoms, probably no. But if you can achieve a R0 resection, do a partial nephrectomy and a metastatectomy, I think we can do a partial nephrectomy plus metastatectomy to get rid of all the tumor tissues. We don't have any data for that, but I think we can do that. For anyone else?
Dr. Sanjay,
I just want to add one comment that
can I? Yeah, you mentioned everything good about the partial nephrectomy, even going to the extent that local control is good. What is the explanation for that? How can you?
The key is these are pre-selected. There is no RCT. In the RCT, there was no difference. So these are all pre-selected. Only the ones that you can get clearance, you have done a partial. The one that you can't get a clearance, the size might be the same. You did a radical nephrectomy. And 10 years down the line, of course, if you compare, size is the same, but the partial nephrectomy will have lesser chance of local recurrence compared to doing a radical. That's the reason.
comment by Anand Kumar sir that if in a situation where it's a solitary functioning kidney and you have to decide it's a T3 disease, you could probably do a partial with some difficulty, whether you should do a radical nephrectomy straight away and then subject for transplant after 1 year or so, or should you do partial? So oncologically, where are we standing? Because for T3, we have almost everyone has agreed that it's better to do oncologically a radical nephrectomy rather than a partial. So that comment was not addressed yet. So could you take that?
So basically your question was,
In a T3 disease or an aggressive tumor biology, and it's a solitary kidney, whether you do radical or and wait for a transplant because then you're given a good oncological clearance versus you do partial and
again, it is a very hypothetical question. I think it's you cannot say yes or no to like you will do for radical or you will go for partial all time. So it's you have to judge the patient clinical scenario, the tumor complexities and everything. I would still believe that if you can do a good partial nephrectomy, even if in a T3 mass, and you can give the patient a advantage of some nephrons with some GFR to avoid dialysis or transplant, because both for dialysis and transplant it has its own complication. Transplant is not complication free hassle. There are so many, transplant may not be successful. So if you can do a good clearance and you are confident, then you should definitely go for a partial nephrectomy. If you can't, then of course you have to go for a radical nephrectomy. And I just want to add one point regarding the partial nephrectomy in metastatic, that I have seen 2 patients who have done partial nephrectomy in a metastatic setting in a solitary mets, and the TKI was started within 2 to 3 weeks after partial nephrectomy, and patient had hematuria and pseudoaneurysm. So whenever you are doing a partial nephrectomy in a setting in a advanced T3 disease, when patient is intended for any TKI, at least give 4 to 6 weeks before it healed up, otherwise there may be a catastrophe in post-partial nephrectomy.
Sir, can I ask one question?
Sorry, I just wanted to clarify on what Ravi has mentioned, VC. So, anybody who is a new onset, as in grade 3 renal failure, who is on dialysis, the risk of him dying is 30% in the first year. Okay. Whether you get a margin positive T3A resection, still the risk of mortality is not 30% in that 1 year. So you have to almost play the God and say, as long as I get a clearance, if he is off dialysis for the next 3-4 years, I have achieved what I wanted to. You won't cure him, but that's the way I would go for it. Sorry, VC.
If that person has technique to do the surgery, T3 tumors, opposite kidney normal, 60 years, something like that, with the creatinine 0.8, we are continuously progressing towards partial nephrectomy because of technical feasibility. Multiple factors like are involved. Non-diabetic, non-hypertensive, 0.8 creatinine, T3 tumor, like morning what Ginil sir discussed. Even after the calyx is seen the tumor, we are telling that even the frozen section is not there. We are telling that cut it and send. That patient is a small age group. But if it is after 50 years, won't you consider all these factors? Even if you are very experienced, is it correct to go remove more than 50% of the tumor? Remove more than 50% of the tumor, and what are the long-term GFR of these small remaining kidneys versus recurrence?
Okay. I think there are 2 questions in that one. I'll just answer one question. Whenever we are asking a patient to donate their kidneys, yes, we are telling them that your lifespan even at 30 years is normal. And here we are trying to offer somebody oncologically inferior surgery by doing a partial when there isn't an actual indication there. So we just need to know when to pull back. Doing a radical nephrectomy in a renal mass is not a wrong thing to do. Yes, I would never make a statement, oh God, how did you? That is what was the indication. So I would rather say I would do an oncologically safe operation, keep him with 1 kidney, 30-year follow-up on patients who have donated their kidney. They are normal. Their actual survival is longer than age-matched control population. So just by doing a radical nephrectomy doesn't mean that patient is going to end up having renal failure.
So we have to close this session before lunch. I think rest of the questions we can take on a cup of coffee or during the lunch itself. So we'll close this session and we'll head towards the lunch. Thank you very much.